I would like to thank the organizers for inviting me to tell you some more about a method you don't need. Well, before going beyond T2, some statements. This is the control panel of an ultrasound machine, and you know that you have to do many adjustments that you get optimal images. And you have to be an expert, you have to be a level 3 sonographer to make these excellent images that you just saw. What about using MRI? Well, what you think is this. Well, mostly you are right, but there are also some possibilities to do it better. Well, good image quality of MRI depends on, among other things, choosing the appropriate parameters that will supply most information. So we have, in the meantime, starting with the 2 different contrasts that we can use to get the best information about the tissues we are looking at. And in these blue frames, you have different parameters that all lead to T2 contrast. The secret is you can achieve T2 contrast by using different settings of parameters. And as it is always, when you use different settings, you will use the wrong one with a certain certainty. So I show you an example. This is gestational week 30. This is a sequence that is available with any machine and which can be used by anybody just pushing the button, and there you are. Now, when you use the correct sequence, you find there is something else because there is a Galeni aneurysm here. And of course, if you use this case for your comparison with ultrasound studies, ultrasound will have made the diagnosis by the Doppler, at least, or by looking at the heart, and then this will go as a case missed by MRI and diagnosed by ultrasound. Well, I was asked some time ago, Daniela, how do you look at the corpus callosum at MRI? Well, I said, well, just by looking at it. But if you compare these 2 images, this done with the wrong parameters, you might understand why it can be difficult to see the corpus callosum. And also why it can be difficult to see the germinal zones, and you will, using this sequence, perhaps miss any hemorrhage that is taking place there. But on the other hand, if you look at the cerebellar vermis, there the resolution is much better, and here you really can see the sulcation. So you must know what parameters you use to answer which clinical question. Well, on MRI, we are less interested to look at the surface because the surface can be excellently depicted with ultrasound, but we are very much interested to look inside the brain. And here you see the zones, the ventricular zone in darker, where all the cells with the germinal eminences, where all the cells originate from the glial cells and also the neurons. And this very important zone, this is the subplate. This is the cortex of the fetus up to gestational week 28. Here are the connections between neurons made. And if you have a malformation or a hemorrhage or an infarction and the subplate is preserved, then you know the prognosis is probably better than if it is destroyed. The cortical plate does not have a lot of function until gestational week 28. And here are more zones, the subventricular zone and the intermediate zone being the begin of the white matter. Well, if you really have good image quality, you can build a spatiotemporal atlas of the fetal brain. I just show you what we have done. You can build 3D models that can be used for comparison in a respective case. And here you have the color-coded map of developing structures with the red one showing that part of the cortex that is developing at a certain gestational age. And you can also have models of the emergence of sulci and compare it with the respective case. That all you can have when you have really good quality T2 weighted images. But of course there are problems. As Gianluigi already mentioned, the resolution is not as high using MRI as using ultrasound, because you see we have rather thick slices, 3 or 4 millimeters, and the fetal brain is rather small. However, we have found ways to improve image quality. You see 2 images here. Here you can recognize the optic chiasm very well, and here not. And you can delineate the aqueduct, and it is not possible here. And all that is a consequence of the use of the correct or not correct parameters. Of course, please don't read this if you're not a radiologist. I just wanted to show you that it really makes a difference when you know what you are doing. And of course, we are messing around with thin slices, 1 millimeter. You see the quality is not so good, but sometimes also this helps. For instance, here you see the septum is missing. Now you want to know more about the chiasm, and you see it's asymmetrically with an atrophic or hypoplastic site on the one side. So this is probably septo-optic dysplasia, and if you are lucky, then you really get the information out of the 1 millimeter slices. But also here I would recommend try ultrasound. If you have somebody who knows what he's looking at, then he will for sure detect, he or she will for sure detect the measures of the chiasm also using ultrasound. T1 weighted sequences. That is the contrast that shows you the brightness of the fat and other structures, and for a long time it was not possible to have good quality sequences because they take longer and there was always movement, but it helped when the mother holds the breath for about 15 or 20 seconds. And why do we need them? Some blood breakdown products are bright on these sequences. You can look at myelin or cell density, at fat. For instance, the lipoma of the corpus callosum can better be detected using T1 weighted sequences than just T2. And the pituitary gland. In some cases, you might want to know, is there a pituitary gland, and is it normal, or is it here, or is it displaced? And meconium is not so interesting in the brain, I have to admit. The same sequence might be used to show flow, here in the carotids, for instance, but this is not as good as ultrasound, of course. This is just the MR, one of the MR method. And here again, you see there are very similar parameters. If you look at these 3 series, and if you look at the pituitary, then you see this is the best choice of parameters. Small structures can easily be missed if you don't use the correct imaging sequence and parameters. And the next thing is, when might you might also use the T1 weighted contrast when you give contrast media. Now you said, wow, gadolinium is not allowed to give during pregnancy. Yes, you're completely right, but there are some situations where you really need it because you have to weigh the pros and cons, and when it is in favor for the pregnant woman, you have to use gadolinium, and then, of course, you have to use T1 weighted sequences, where you will see an enhancement, as for here, for instance, here in the placenta and also in the brain. T1 weighted contrast can also be achieved with another type of sequence that we call the FLAIR sequence. I show you when we use it. At first, you know the subplate resolutes after gestational week 28, but it does not resolute at the same time in every part of the brain, and it stays longest in the frontal parts. And if you really want to have another information whether brain development is going on normal or not, you can use this sequence because it will show you the age-related remnants of the subplate better than using T2 only. And of course, if you have lesions that have the same intensity as CSF, for instance, these cysts, it's easier to depict them using the FLAIR sequence that gives you the CSF dark and not bright. Hemorrhage. We have special sequences, especially this one, that allows us to detect blood breakdown products. Well, if you have a large hemorrhage like this, that might not play a role. But for instance, if you have unilateral ventriculomegaly and you find some blood products there, then you can say, well, this is not a malformation, there has been a hemorrhage some time ago, and you can do the workup on the cause, what may cause hemorrhages, and you can skip the whole malformation thing. Diffusion-weighted imaging. Well, diffusion-weighted imaging, I will show you in a minute what we are using it for, but it is very important to have the region of interest, the brain, quite in the center of the coil. What is a coil? A coil is the element where the signal is received by MRI. It is wrapped around the pregnant woman, and if the elements that receive the signal are not above the brain, you will have images like that. And this does not help at all. So if you have good images, for instance, you can make diagnoses that you cannot make using T2-weighted images. Here, for instance, you see nothing, but here, this bright structure is a recent infarction in the boundary of the medial cerebral artery. But diffusion allows you also some types of diffusion-weighted imaging to detect white matter structures even if they are not yet myelinated, as for instance the corpus callosum. Here you have a normal case, and gestation week 22, a case where you can only see the knee of the corpus callosum. If you do T2 only, you will miss that diagnosis, but you will have seen it by ultrasound before anyway. Well, you can also use diffusion-weighted imaging to do so-called diffusion tensor imaging. I'm showing you just, this is the sequence running for a minute, then you have a color map and an anatomical map so that you know where you are, and based on this information, you can do tractography, the corticospinal tract, and the sensory tracts, for instance, in young fetuses until gestation week, radiologically young fetuses. That means beginning of second trimester or middle of second trimester. You see these tracts, and you can, of course, find the fibers of the corpus callosum. In older ones, you get a lot more fibers of connectivity, and we are interested especially in the fibers such as the uncinate fascicle in the temporal lobe, as these tracts may be involved in speech development, and we are working at the moment on looking at these informations, whether they would allow us to make better prognosis than without having these informations. Of course, we are not always sure whether it's correct what we are seeing. Here we have a comparison in vivo and post-mortem, and as you can see here, this prenatal information of corpus callosum agenesis in trisomy 13 was quite okay, because this is the post-mortem study which shows almost the same. Now you will say, this is science, and how do I apply this to a patient? Well, for instance, I show you only one case. You see hemorrhagic remnants in the glomus of the choroid plexus here, and some sort of hydrocephalus, and the parents wanted to know, will my child be able to move on the right and left side? Well, so yes, you here see also hemorrhagic remnants causing that hydrocephalus that you perhaps might have missed using T2 weighted images alone. And so we do tractography, and when you find the corticospinal tract, there is at least not a morphological reason why there should be any impairment of movement, and this is the postnatal correlation. So, if you see a tract, then this is good news. What happens if you don't see a tract? Does it mean that there will be hemiplegia? Well, this would be premature because you know about brain plasticity, and we have seen brains looking like that, where the function had shifted to a part of the brain where it is not supposed to be. So it works only in case you can see a white matter tract, but not quite the same if you miss to prove it. Spectroscopy. Spectroscopy is an MR method that does not lead to images, but to curves, like as you can see here. You can see several peaks, and you cannot choose what you want to see. You just get the peaks, and you have to do some interpretation. For instance, choline is a marker of cell turnover, and as there is caused by the growth of the brain, a lot of cell turnover, this choline is higher during the second trimester than during the third trimester. Then you can see creatine as source of energy level, and acetyl aspartate, which is a marker of neuronal function and which will rise during the choline peak goes down, and then you can see lactate. Now, if we see lactate in a brain that is older than 1 month after birth, then we say it is pathological. In fetuses, this is different because fetuses sometimes live on lactate, so there is still a great confusion from when lactate is not normal or not. I think Magda has done a study on IUGR fetuses where she tested the significance of brain lactate there. And depending what parameters you use, you will also have peaks in a region where you know it is maybe macromolecules or lipids, and this might be important in the diagnosis of some metabolic diseases, and also myoinositol can be seen. This is a marker of glial function. I'm only showing you that. I'm not going into details, but well, I'm coming back to the small structures and the T2 information. We are all interested in brainstem function. Why? Well, this is easy. If you have no brainstem function, you will not survive. So, you can detect some myelinating structures, but this is not enough. So what we are looking at using MRI is the output of the brainstem. So what, at first, I go over this. Of course, you can do signal measurements and they help somewhat, but for instance, we look at eye movement. This is not a new idea. It was done in 1981 by Bernholz. So the first step was that we tried to reproduce what he had already described by ultrasound, the different types of eye movements. Here you have a complex sequence, type 3, and here in the older fetus, it's 32 weeks, you have a nystagmoid sequence. Well, how can we use that? Well, there are situations, as you know, when the brainstem is compressed. Here the Chiari-2 malformation, and here is just a schematic drawing out of the paper of one of my fellows that shows you what are the main functions in the brainstem. So, if the eye movements, the conjugate eye movements work, then you know the basic functions of the brainstem are preserved. And this is, here you see, there is very immature eye movement, which is not in keeping with gestation week 32, so we might have here some damage of the brainstem. But we still, of course, need larger studies to prove that. Next thing is, we did a model where we can quantify these eye movements and where we can also calculate the movements of one eye and the other. And you will ask me, well, in Vienna they must have a lot of time, because that does not make sense. It looks nice, it's perhaps good for a publication, but this is typical radiological stuff, and nobody can see what we can do with that. Well, coming back to the brainstem functions, there are some reflexes. There are some reflexes you test, for instance, when a patient is supposed to be brain deaf, and when these reflexes still work, then you know the patient is not quite brain dead. One of these is the vestibulo-ocular reflex. So, well, the vestibulo-ocular reflex even works later. So please, we will make a test. Please look at me. And I'm moving now. And you still saw me sharply? Or was it blurry? So, okay, then if you saw me sharply, then you know you are not brain deaf. Okay? Well, and this is just an example of a fetus after gestation week 30. You see it turns the head and the eyes stay centered. And this is very often combined with the movement of the hand, as you also can see here. This is, of course, research in the beginning, and I'm not going to draw any conclusions whether we will be able to applicate it. But what we are already doing is functional MRI. You know, functional MRI is, oh, I forgot the slide, it doesn't matter. You know, functional MRI exploits the oxygen consumption of your brain, especially in a region that you are using now. So as I'm expecting all of you are already sleeping, perhaps we won't find any activity. But, however, even if you are sleeping, your brain is active somewhat, and we call it a resting state. The resting state is the basic cerebral activity, and usually when you do this with the patient, you tell him, relax, stay awake, lie still, eyes closed, think of nothing. Well, we thought it was a perfect working place description for a fetus, and so we tried it. We know how it looks like because we know that are low frequency fluctuations, and we know that they are organized in networks. And wow, how do we know it? Oh yes, we know it from studies with adults, and that is how it looks in adults. And this is just an example how it looks in fetuses from gestation week 20 to 36. What you're looking here is at the frontal network that stays quite constant during all these ages. And we have already gone one step further. We quantified these networks, and this looks rather complicated because it shows all the points that we designed here, all the anatomical points, and then we tested when the networks were developed. And when I say we, that's not true, because the guy who did it is just a scientist, not a neuroscientist. He is an informatics and informatics specialist, and he said, well, it is strange. There is a hierarchy because at first the occipital network develops, then the temporal and parietal, and the frontal at last. Well, we found it not so surprising because this is exactly what happens with brain maturation. At first your visual sense develops, and then the hearing, and the motor, and at last the frontal brain. So perhaps this is correct, I don't know. We will see it in some years. Last point, field strength. Perhaps you heard, usually we use 1.5 Tesla because we know it is fine, the patients feel good, but we also know from our experience postnatally that higher field strength sometimes gives better resolution, and so it was tried and is tried in many centers to go to higher field strength. Well, SAR means the energy deposition is higher, but and it is hotter. That is really true, because our pregnant women who are in the 3 Tesla magnet, they all sweat. And also we did a study where we objectively measured the temperature in and out of the magnet, and it is hotter. It is not as agreeable as 1.5. You have problems with amniotic fluid. You can get rid of that with a technique that is called multi-transmit. The susceptibility, that means the sensitivity to detect some blood breakdown products, for instance, this is better using 3T, and also spectroscopy, for instance, and this is the indications where we use it now. And I just show you an example, a fetus with 3 Tesla and 1.5 and the respective sequences, and you will see that the resolution is really better. And what is excellent is fiber tracking, because there it is much more accurate than using 1.5. Now I have troubled you enough, and I was just take home, please. MRI of the fetal brain should include T1 weighted sequences. If you do them, please do them with the correct parameters. T1 weighted sequences, echoplanar sequences, diffusion weighted sequences, facultatively tractography or spectroscopy, and in the future functional MRI, perhaps eye movements, and higher field strength for selected indications. Thank you very much for your kind attention.
Any questions to Daniela? If you want to look at the parameters of the sequences, do you have any question or recommendations to Daniela how to change the sequences? We'll be glad to hear about that. If someone have a recommendation.
It's all in the book, and the book is outside.
No, but perhaps they want to give you a recommendation.
Oh, yes, okay.
Thank you, Daniela.